So we are going to immediately transition now into our first faculty panel, moderated by Laura Ferry. She's Vice President and President's Professor for Knowledge Enterprise. Our panelists include the esteemed George Poste, Chief Scientist and Regents Professor in Complex Adaptive Systems Initiatives, along with myself and Fang.
So while my panelists come up here really quickly, I'll just offer you a quick welcome from myself and from Knowledge Enterprise. I'm so excited to be here today. I can't even tell you just the incredible joy in my heart to see everybody here in person, talking about great research that we're going to continue to do and move forward in this space. And what we want to talk about a little bit today is in Knowledge Enterprise, one of the things we try to do is to position Arizona for impact and ASU to impact Arizona, right? And we want to come together to identify those areas where we can create really positive outcomes for our communities and for Arizonans around us, right? This is a great example of ways we can lean into that goal. All right, I'm going to try to move. So, which microphone to use? I'll take this one. Could I start, I think, by asking each of my panelists to briefly introduce themselves? I'll start with you, George. Thanks.
Good morning, everyone. George Poste. I head the Complex Adaptive Systems Initiative at ASU, which is a very broad dimension, ranges obviously a lot of issues in health, hence why I'm here today, but a large part of it is also infectious disease, epidemiology, and counterterrorism. So it's a very, very broad agenda.
Thank you.
And I'm Matt Buman, professor in the College of Health Solutions. I'm trained as a behavioral scientist and exercise scientist with a focus on behaviors across the 24 hours, so sleep, sedentary behavior, physical activity. Also lead the Precision Health Research Initiative within the College of Health Solutions, where I just described a bit of our goal, which is really leveraging technologies in a way that can help deliver more effective interventions to communities.
Hi, my name is Fang. I'm a nurse and gerontological nurse practitioner. My research is mainly in preventing and treating Alzheimer's disease. My passion for this population usually stems from my practice as a nurse, taking care of them at the bedside.
Thanks. And I'm, by the way, actually broadly trained as a comparative physiologist, and my research is in the animal functional morphology, which is sort of kinesiology of animals, if you will. So also having a good time just in my science life today. I'm going to start with Matt, and I'm going to, just for all of you, try to keep us kind of to the time limit, because I know that we're now standing between you all and the next sort of break where there's this really great food sitting over there. So I'll be looking at my watch, but I am paying attention. Matt, can you tell us more about how digital health has the potential to impact both health and healthcare?
Yeah, so I think I started to outline that a little bit in the talk, but I really think that the challenge and the opportunity is how do we more effectively take data that we can generate voluminously and at very low burden across populations and take those data and make them into information. And that's AI and all of those methods, but it goes far beyond that. I think we all can understand that AI is sort of perhaps an entree into that, but it's really about what information works best for whom under what conditions, and really understanding that and giving that power back to the patient or the individual to help make sense of their own data. Some of the work we've been doing lately is asking, well, how do we build trust with communities in a way that they want to engage with us around data and around information. So that's a value proposition for communities, for individuals, right? This is not something that people readily want to hand over their data. If you imagine how social media is so effective, it's because they provide what is perceived as a great benefit to the individual user. And so users are quite happy to hand over a lot of data to them, right? Well, can we use that to the benefit of health and medicine in a way that makes people excited to engage with us, interact with their data, feel empowered about their data in a new way. So that really requires, yes, advanced analytics, but also deeply embedding ourselves in the communities that we're engaged with to understand what those challenges are, what those concerns are, and be able to adapt and refine our technologies in a way that meets their needs.
Thanks. And Fang, I wonder if you could add to that just a little bit in sharing with us how these digital technologies can be used to really address those health disparities, specifically for Arizonans.
Thank you. That's a very good question because health disparity in a nutshell, there is access issue and there is availability of providers who can provide the care needed. With technology, now that barrier is being reduced. For example, telemedicine that can provide virtual care to people who live in the remote areas. Mobile clinics can bring clinic to people where they live so they can be taken care of right there. Another exciting piece is M-Health, using smartphones to deliver interventions. The M-Health not only empower the people to take care of their own health, but it also provide a monitoring tool to providers potentially can see what's going on with their blood pressure, what's going on with their glucose level, how much physical activity they are doing. So timely changes in care can be provided. And the other area that I'm super excited about is virtual reality or XR gaming. We have designed some XR gaming intervention to help people make exercise fun, because who wants to be on the treadmill for 30 minutes, right, doing nothing? Some of the machines right now have virtual environments, but what we designed is actually a cognitive gaming you can do as you exercise to make your pastime away. Our participants were surprised, like they were doing it for 30 minutes without knowing it.
That's a great outcome. And I wonder, Matt, if you could elaborate. You mentioned earlier in your presentation that there were fears that digital health could increase the divide rather than decreasing the divide. What are some of the new ways to better engage with those communities and rural communities in particular?
Yeah, so I think that one of the important things to think about let me take a step back and say, we often think about technologies first and then try to find the problem that it solves. And we often will still just develop the technology and then try to figure out what that problem is, instead of starting the other way. And I think that if we start with what is the problem that needs to be addressed, and we move in that direction, then we're really going to be meeting the needs. And obviously the problems in underserved communities and a lot of disenfranchised groups are really big problems, and they need to be solved. And technology can help support them. But when we start with the technology first, we tend to go to those who are most readily and easily able to adopt that technology first, and we can then create a greater digital divide. But if we can really start with the communities themselves, these are things like community engagement, something we've been working on, Design Studios for Health, human-centered, user-centered, iterative design processes that really help us engage at a very individual level with individuals. Then we start developing technologies that truly meet the gaps and the needs that are important.
Thanks. And turning to George now, Matt alluded to earlier that there's scads and scads of data that could be presented through some of these technologies. What are some of the issues we face around data and artificial intelligence right now?
Do we have 2 days?
Yeah. Only about 5 minutes, sorry.
No, I mean, I think there will probably be a number of overarching themes that we hear throughout the day just looking at the agenda, and I think one of those clearly is scale. We have to constantly think about scale, data, but as Matt emphasized it in his lucid introduction, it's not just data, it's actionable information. And I think, again, we come back to the issue which we just touched on, namely, as a techie, it's easy to sort of say, oh, wow, this is great. And then you actually ignore the end user in this, whether the end user be a healthcare professional or a consumer or a patient or their family. So I think that all these things get mixed in. But I think we are on the cusp of something clearly very unusual to the extent that the type of fact I'm going to give you now you can dine out on tonight, namely the healthcare generates currently 10,800 exabytes of data per year. And it's estimated that only 90% of that, and that's probably being generous, is actually used for impact on patients. The rest is trapped in data tombs. And as we look at healthcare and everything from fundamental research all the way through to translation to impact in the clinic or keeping people healthy outside of the clinic, we have to basically sort of look at these principles as we navigate. And we can clearly come back on the daunting challenge that digital health represents in terms of the diversity of tracking modalities which can now be used from the wearable, the beast on the hip, everything else, the instrumented home, all these issues that then follow. But it is this issue.
Jordan.
Maybe just put your mic just a little bit closer, I think.
Sorry, my apologies. So this issue of already been touched on, how do we deal with this data deluge of multimodal data coming at us, everything from the Fitbit or some other beast on the wrist or on the hip or the back pocket, all the way through to the instrumented home, these enormous data flows. And so that we're not too anthropocentric, we need to think about this also in terms of environmental sensors relative to particularly social determinants of health, toxic exposure, in environment, and certainly I think the ASU Health Observatory I think is clearly going to be something where we try and look at large-scale data capture across the health of Arizonans at large. But that must also, I think if you go to the infectious disease world, 90% of what has bitten us in the last 5 decades are all zoonoses. They come from animals. So the issue of sentinel sensors in animal populations is also something where we're going to see, I think, a lot of important developments. But we can come back to the vagaries of data analytics, the patterns of data flow that have to be captured, and the computational demand, and then a little later the implications for the academy.
Thank you. So, Fang, would you tell us more about the new Roybal Center, how this is developing technologies specifically for aging adults with cognitive decline, which is a particularly large and vulnerable population here in Arizona?
Thank you. And earlier, Dr. David Kuhn has mentioned how ASU come to this stage of supporting the center by building the infrastructure. For myself, I actually came across and become interested in this population about 10 years ago when I went to a conference where Europeans were describing their findings showing older adults actually prefer to live alone by choice. That was very eye-opening for me, and subsequently I have learned even in the United States, many older adults who live alone prefer to live alone and desire to continue to live alone at home. So that made me think, okay, then we need to empower them. We need to help them to live alone. I mean, some of them are not living alone by choice for sure, but how do we help them so they don't transition into long-term care? They can remain independent as long as possible. And that's where technology can marry this population and helping them to really live at home and stay independent. And that's the scientific theme of our Roybal Center.
Thanks. And I'm going to pass back to you again, George. In your opinion, in this space where you've been giving it a lot of thought, what are the partnerships that ASU needs to leverage to enhance research and educational opportunities to include workforce development so that we can really move this forward?
Again, I think it comes back to this issue of scale. The data flows that we're going to have to handle and integrate, by definition, means that compute scale becomes very important. But I think the broader issue is almost cultural, and that is the fact that the academy probably lives on the basis of silos still. Clinical medicine lives on the basis of silos, and so how do we actually begin to think about how those barriers get broken down? Otherwise, 10 years from now, we're still going to have completely compartmentalized data sets, which are useful only for those subsets of individuals, whether they be in the research lab or dealing with patients. And I think that this is going to be one of the cultural element of this is going to be quite formidable, because it's a cultural translation within the academy. ASU is probably further down the curve than most in multidisciplinarity, but compared to industry, we're nowhere close to being multidisciplinary. The whole grant structure is still tragically individually oriented. R01 grants are very difficult to get, but for the most part, they're completely insufficient to deal with the problem sets that we have to deal with today, hence why something like a $5 million grant to Roybal is precisely to such scale you've got to think about. I think that the other cultural dimension in this then is the reward structure in the academy for teamwork as opposed to individual activity. And then, of course, so many of the things we'll be talking about today, many of the major conceptual and technological advances now are occurring in industry rather than the academy. So we have to really think about industry as an absolutely key partner. So back to scale, I think that there are two elements. One, internal scale within the institution. Academic consortia are now becoming increasingly commonplace, because in order to access very large patient sets, you need to have that coordinated consortia. And then the translational element of this really has got to have a very key industrial component. And I think that the biggest mistake that academics can make in dealing with industry is to say, with our brains and your money, we can do great things, and they immediately shut the door on you. You actually have to think long and hard about what is, just as Matt said, when you think about why am I developing this for its impact, you also, when you go to industry, I don't mean to be patronizing in this comment, you've got to think about what is the value proposition for them that you're talking about, rather than just saying we got a lot of smart people.
Thanks. So I'm going to invite each of our panelists to just offer a closing thought as we've gone through this discussion. Fang, I'll start with you. Anything you want to make sure you leave the audience with today?
Thank you. I hope you take the opportunity to get to know each other, build networks, and get great projects going.
Thanks. Matthew, anything?
Yeah, I know we have. I know what the time is. So I've got another extra minute or two. So what Fang was talking about before reminded me of something that I think would be fun to share. So many years ago, when I was doing my postdoc training, this was early stages of mHealth kinds of interventions, very, very early. I think my mentor got one of the very first NIH-funded mHealth studies ever funded, so this was a long time ago. But we were doing a project where we were trying to develop technologies that would help older adults survey their communities to understand the physical activity in the food environment of their communities. What is available, what's not available, what are helpful and unhelpful tools. And this, we started with what might be one of the more challenging communities, and that was low-income older adults living in senior housing. And of course, people said, why would you start with technology with this group, right? And we had some really strong rationales to why we would do that. And they said, well, they're not going to use it. Like, there's no way they're going to use this technology. So we went into these senior living facilities and just started asking questions and started to understand what their needs were and how we could actually empower them and help them be better advocates for themselves around their food and physical activity environments. And through that, we developed a technology. It wasn't a smartphone. These are individuals that didn't have smartphones. In fact, most of them had never touched a smartphone in their life. But we developed a tablet technology. So we built it on a tablet because that's what they wanted. They wanted big buttons, big pictures that they could see out in the sun when they're walking around their neighborhood. And we built these little lanyards so they could hang it around their necks, so they could walk around, so they could be hands-free and be safe as they're walking through their neighborhood, while they're then being able to interact with this technology on this 8-inch tablet. And we thought this was great, and we've published several papers on this showing that we can actually quickly help train older adults to be advocates for themselves and actually instigate policy change. But the most exciting change was not one that we really were thinking about, and that was empowerment. So these older adults said again and again, you taught me how to use this technology and I feel empowered by it. And all of a sudden they're out doing other things, actually standing up at city council meetings and advocating for change and creating policy change, these older adults living in senior living facilities. So I say all of that to really illustrate that when you really engage with individuals around what works best for them, the technologies that come out of that are far more effective and valuable than ones when you really already know what you want to develop and you're just trying to demonstrate its efficacy without asking and engaging with those communities.
Thank you.
Thank you for indulging that.
Absolutely happy to do so. And George, I'm going to give you the final word.
Well, again, I come back to this issue of the broad dimension of culture, insofar as with my gray hair, the reason one went into the life sciences or medicine is you didn't have to do math. Now, we are headed towards undoubtedly a new era of data science, actionable data, but I think that the whole question of looking at the unit rate of change and the constant omnipresent threat of technological obsolescence, for whether you work in the research lab or in the clinical interface, is very real. I think we've got a great opportunity at hand with establishing a new medical school, a new school of public health technologies, to really be thinking. I don't minimize the difficulty of superimposing all these rapid technological changes on top of an already demanding curriculum for MD or MPH, but we've got to really think long and hard, because we're going to be back into a constant cycle of re-education and training to prevent technological obsolescence, because the other cultural element is the issue of, and we haven't really touched on it today, but I think it will become increasingly important, at what point will we move to sort of what is colloquially referred to as agentic intelligence, namely taking humans out of the loop, and what are the frameworks by which humans will remain in the loop, and one can understand the sensitivity. Hell, I've just got 4 years in an MD, 7 years to get my board certification, and now I'm replaced by a totally autonomous system. So I think there are a lot of very interesting challenges to be navigated, and I shall be retired.
Thank you, George. Do you have any final comments you want to make, or should I dismiss them to the coffee break?
Well, thank you so much to Laura Ferry and to our panelists for this great discussion.